Okay, I think we'll get started. Welcome everyone and happy June. I hope wherever you are, you're enjoying the temperatures warming up. And today we have Doctors Joe Winger, Greg Samsa, and Tammy Summers presenting Designing Persuasive Psychosocial Intervention Pilot Studies, a tutorial for palliative care investigators. Just a few housekeeping items. Attendees are muted and video cannot be turned on. We wish for you to engage with us by typing your questions in the Q&A feature, which is a button at the bottom of your screen, and also commenting in the chat. Today we have Dr. Tamara Summers moderating the session, and Dr. Summers is an associate professor in the Department of Psychiatry and Behavioral Sciences at Duke University School of Medicine. She's a member of the Pain Prevention and Treatment Research Laboratory at DUMC and a member of the faculty at the Duke Cancer Institute. She also serves as co-director of the Clinical Studies and Methodology Core for our own PCRC. So Dr. Summers, I'll turn it over to you.
Great. Thanks, Naomi. Thanks to everybody for being here today. I'm excited for you to hear from Dr. Greg Samsa and Dr. Joe Winger on the topic of psychosocial intervention pilot studies. I'll first introduce them and let them take over. So Dr. Greg Samsa is a professor in the Department of Biostatistics and Bioinformatics at Duke University. He directs the institution's Research Integrity Office and also serves as the Director of Graduate Studies for the Masters of Biostatistics program. His time is divided between administration and collaborative studies, the latter with an emphasis on palliative care and oncology. Dr. Samsa previously directed the PCRC Data, Informatics, and Statistics Core, which provides support to investigators, sites, and studies in the statistical and data-related aspects of trial design and data analysis. We're also fortunate today to have Joe Winger, who's an assistant professor in the Department of Psychiatry and Behavioral Sciences at Duke. Dr. Winger's research focuses on novel psychosocial interventions for patients facing life-limiting illnesses. His work emphasizes addressing the existential aspects of coping with debilitating symptoms, particularly maintaining a sense of meaning and purpose in life. Grants from the American Cancer Society and National Palliative Care Research Center support his work. Slide 4, please. Thank you. Here, the three of us acknowledge relevant support. Again, thanks to everyone for being here. Please feel free to use the question and answer throughout, and then we'll make sure those questions get answered at the end. So now I'll hand it over to Dr. Samsa and Dr. Winger to present. Thanks.
Great, thank you, Tammy.
Great. Well, I can describe, if you like, the basically the impetus for today's tutorial. It was one of the PCRC's intensive short courses on designing and performing randomized trials within the palliative care space. So as the course progressed, we realized that although most of the information available to new investigators is about those definitive phase 3 efficacy trials, which come very late in the intervention development sequence, many of the participants in the intensive, in fact, were far earlier in the sequence. Namely, they were doing pilot and feasibility studies. That led us to develop a presentation for the next intensive organized around the key goals of a pilot study and also a manuscript, which is referenced on the slide. So today's tutorial is based on those materials and also the questions and the wonderful discussions we've had in the various intensives around this topic. So I hope this tutorial will be useful to you.
Great, thank you, Greg. Yeah, so I just wanted to start with an overview and give an outline of where we're headed. Thank you all for joining today and those who are going to watch the recorded version of this. I find talking about pilots really interesting because a lot of my time goes to like thinking through these things. And so our goal with this was to put a lot of good ideas in one place because there are a lot of other resources out there for developing pilots, but I found that I had to like piecemeal them together. So hopefully this can serve as a comprehensive stop for some key goals of a pilot. So we'll begin with some basic introductions and common pitfalls to avoid. And then I'll get into the overview of the 10 goals that you're seeking to achieve with a strong pilot. And at that point, we're going to stop and take questions. So as Naomi was mentioning, so please use the Q&A feature, and Dr. Summers is going to moderate that. And then if we have time after that, I have some additional slides about examples of our key points pulling from my own pilot work. So I can get into that if there's time, but I would love discussion, which I think would probably be even more helpful for you all. All right. So introduction and common pitfalls. First off, I think it's important to take a step back and define what we mean by a psychosocial intervention study. So it's a very broad term. If you go to the literature, you're going to find this encompasses a lot of different types of interventions. This includes things like psychological, social, and behavioral aspects of palliative care. Some concrete examples of what you'll see are things like psychotherapy, behavioral symptom management, music therapy, psychoeducation, patient-provider communication, care planning, and coordination. So I would say those are probably the more common types of psychosocial interventions we see in the palliative care space. But just know it's a broad term, and essentially what we're not saying is drug trials. So the steps we're providing here are not going to be the same if you're doing like a drug trial, which I'd assume most of you, if you're tuning in, that's not what you're doing. So we're talking about psychosocial interventions. And some definitions on like, what do we mean by a pilot study? The official definition is that a pilot is a small scale test of methods and procedures to be used on a larger scale. So what this means is inherently we're dealing with elements of feasibility and acceptability. What I think is interesting about this definition, though, is it doesn't specify anything about the comparison group, about whether or not randomization is used. These types of questions really come into play when you're thinking about the next step. So what is it that you're building towards? And we're going to come back to this idea a lot because I think it's the unifying framework here is a pilot is all about what you plan to do next and then working backwards from there. And so things like your comparison group, whether there's randomization, a lot of those decisions have to do with what you're planning to do as your next step. And so the goal is that you design your pilot so you're really well positioned for that next study. And we'll give you some concrete tips as to how to do that as we move through this. So the emphasis of this tutorial, I think, is important to point out too. We call it designing persuasive pilot studies. So who are we persuading? Grant reviewers. So grant reviewers of your pilot application. So whether that's, like an R21 or if it's an internally funded grant or an association or a foundation award you're going for, as well as the subsequent application. So that's a big deal, right? As you're building your pilot to be the preliminary data for a much larger application. So keeping those things in mind at every step, I think is critical. And remembering just who grant reviewers are. So it's you, like it's people like us. It's people who are reviewing these things late at night, who are, very busy clinicians and researchers. So all of those things in mind as you think through, if I were reviewing this, like what would I be looking for? And again, with a pilot, our key things, we're going to be focused on, is this feasible and acceptable to patients? And another key point with this is that the emphasis of this tutorial is building towards an efficacy trial with a really high level of internal validity. So we're talking about things like a manualized protocol, making sure the interventionists have a high degree of fidelity to the protocol. So all of those things assume you're building towards this really tightly controlled efficacy trial. If your next step is to move into like implementation type work, not all of these recommendations are going to be the same because as you move towards doing more type like implementation work, you're going to start to loosen up some of the controls you would put on a really tightly controlled trial. So just a few opening caveats to keep in mind as we dive into the key points. And pitfalls. Anytime you're talking about pilots, I think you have to highlight the important pitfalls to try to avoid. Most, if not all of these, relate back to the fact that you have a very small sample size. So pilots typically in this area, if you look at the literature, you'll find between 10 and 75 participants per arm. There's some variability with that, right? You'll see some pilots that are actually quite large. But in general, we're talking about very small numbers. And a basic rule with stats is the smaller your numbers, the more unreliable they're going to be. And so just to keep that framework in mind as you're thinking about your study and what those main aims of the trial are. So a pilot should not primarily focus on things like safety, efficacy, and effect sizes because of this issue of having a small sample. During my graduate work, I was teaching undergrad statistics. That was one of my roles, and I would often talk about how unreliable like small numbers are. So we would do this exercise where the class was my population, so it'd be a class of 100 students, and I'm trying to calculate the average height. So if I just select 5 students, right, to get the height of my class, and I grab one basketball player, our mean is going to be super skewed. It's going to look like we have, very tall class, but that's not really representative, right, of the full class. It would be much more towards the average height. So the point with that, right, is like the smaller numbers we get, the more unreliable they're going to be. And where this pans out with pilots, so I'll pull from my own work here. So I did a pain management study. So it was patients with advanced cancer. And we had this 4-session protocol, and we were seeing, like, does this help them manage their pain compared to usual care? Like, is this better than that? But in a pilot framework, so we didn't have too many participants. And we did assess patient-reported outcomes at the end, though, to see, like, in general, what was happening with the measures. So after the intervention, we get the data back, and we see that immediately after the intervention arm seems to be doing better. So compared to usual care, there was an effect for physical well-being that was like in the moderate range. So it was 0.51 was the Cohen's D. And so I'm thinking, like, this is awesome. Look at this, it worked. This is proof. And then I look at my confidence interval. So, okay. So now I'm 95% sure the intervention either was a little bit harmful, right? So their psychological well-being was worse afterwards, all the way up to like this amazing impact. So the point is, like, the confidence around this moderate effect size, the confidence interval is so large, this tells me very little information. It honestly brings up more questions than it's answering. And so essentially it's just telling me I don't have enough of a sample size to make any type of conclusion about what happened. Anyway, so just a lot can be said about small samples, but in general, this is not going to be the focus of your pilot. It's not about the effect sizes or estimating efficacy. Okay, so introductions and pitfalls aside, so what are the key goals of a pilot study? We broke this down into 10 separate goals, which we'll dive into, but a broad overview. The first one, which really ties them all together, is this idea of beginning with the end in mind. From there, we'll talk about a formal conceptual model, and then thinking about the patient-reported outcome measures that you're using, or whatever measures, as long as they, just thinking about their psychometric properties. And then the justifying and timing of the study sessions and assessments. So making sure all of that makes logical sense and fits with your conceptual model. And then a big deal with pilots and the subsequent trials, recruitment methods are key. And then looking at retention and assessing the interventionist fidelity to the protocol. And assessing the acceptability of the intervention. We'll talk about different ways of doing that. And then a lot of this is talking about feasibility already, but then tying it down to what are your actual feasibility benchmarks. And then at the end of every study, you're going to have a list of barriers to the next study. So thinking about what are the things, if we don't address, could get in our way of doing the next study. All right, so let's jump into each of these. So first, beginning with the end in mind. So there are a lot of different intervention development frameworks out there. I'm partial to this one. So this is by Onken and colleagues, published in 2014. And it's the NIH stage model for behavioral intervention development. So it talks about 5 different stages. As you'll see, they're in a circle here and lots of arrows going different ways. And all of that's to point out that these aren't necessarily sequential. Is you may start at like stage 1 and doing some preliminary work, and then have to backtrack and go back to maybe there's some basic research that needs to be done before you're even developing the intervention. Likewise, you may get up to an efficacy trial and realize, you know what, we need to take a step back and revamp the intervention before we start trying to implement this in the real world. So I like it because I think it's realistic that it's very rare to just go from one trial to the next and have it progressing exactly as you expect. Is at each stage, you're going to get new insights that cause you to backtrack. And I think that's part of the beauty too of doing intervention work is there are always other studies to be done. And the more work you do, the more it opens up those ideas. There's also other ones like the orbit model is a commonly used intervention framework. But yeah, the point here is to find a framework that fits with your type of work and to use that to guide the steps that you're taking. And to think about things like if your ultimate goal is to implement an intervention, that can affect your decisions early on. Like if you're developing a very complex protocol that requires lots of highly skilled interventionists, just thinking about how those types of decisions early on can really be barriers to implementation down the road. And so seeing if there's anything you can do to set yourself up well from the beginning. So even thinking about like payers, like, are you addressing a problem that's of interest to people who could eventually be paying for this intervention? So those types of questions, I think the earlier you can think about them, the better. And then this one, Greg told me this step a long time ago, and I keep coming back to it. I think one of the key things you can do to set yourself up well is to draft the part of the proposal for your next study. So at a bare minimum, I would think about the specific aims page for the next study that you're going to do in your line of research. So if you're doing an R21, what's the R01 aims page going to say? And Tammy's pointed out the importance of writing your whole preliminary section that you would put in that R01 application. Like, are there key sentences that you want to collect in your pilot data? Like if you're going to be using an app, is there something that you could be pulling from your pilot work to say, here were how many participants that had access to the app and used it correctly and already had a smartphone that could be used? So those types of key points that would make a really great sentence in your preliminary study section, make sure you're developing your pilot to answer those questions so you can pull from that. All right. And then the second point is to use a formal conceptual model. So at a high level, this is just talking about how and kind of the mechanisms behind your intervention. How is it supposed to work? And it can really help you identify the key constructs too that you should be assessing. So an example from my work, so I'm interested as Tammy mentioned in the beginning, so like the existential aspects of coping with symptoms, particularly pain is one of the main symptoms I look at. So an overarching framework that I pull from a lot is the biopsychosocial spiritual model of pain. So here this is, it's really broad, but it does tap into the point that there are a lot of complex factors that interact to contribute to poorly controlled pain in those with advanced disease. But then I also, to talk about my intervention work, I need to pull in another model as well, because the types of skills that I teach in my intervention are very much based in social cognitive theory. So like for this theory, a big part of it is self-efficacy, is doing what you can to boost the patient's confidence that they can cope with their pain. And you do that through things like modeling skills for them, teaching them how to practice those skills in real world settings. So anyway, all that to say is these are two models that I pull from to really conceptualize the intervention work I'm doing. And so whenever you're thinking about it, and your intervention, just it's critical to make it fit into a conceptual model. And yeah, in terms of like thinking through what things should be primary and secondary outcomes, which things are your mechanisms. So all of that can be helpful. And it's also really common that one framework may not capture everything that you're doing, or it may not fit exactly, and that's fine. And I'm usually explicit about that, as I'll say, like, I'm informed by the biopsychosocial spiritual model of pain, but here are the pieces that we have shifted a bit, or here are the parts of the model that I'm really focusing in on in this application. Yeah, so using a formal conceptual model. And then using measures. So along with your conceptual model that will feed directly into the types of outcomes you're measuring. And it's best to use measures with strong psychometric properties. So in an ideal world, we're talking about published validity studies in your target population. And so those are measures that are also reliable, both internally and over time. And this is a key piece, if you're doing intervention work, is make sure you're choosing constructs that are responsive and sensitive to change. Primarily for like your main outcome. You want to make sure that you're assessing something that theoretically should be something that could change, in contrast to something like a personality trait that may not shift over time. Yeah, so make sure it's responsive to change. And in the ideal world, that it has an established minimally clinically important difference, so an MCID. The point we say this is because your subsequent efficacy trial is likely going to be powered to detect an MCID. And so if from the beginning, you can have things centered around an outcome that already has data for this in your population, that would be the best scenario that you could be in. But we realize this doesn't always happen, especially in the palliative care world. There may not be a lot of research in your patient population. So if you don't have valid measures in your very specific niche population you're studying, one thing is to pull from similar populations. So maybe you're studying a really rare specific cancer type. If it's been studied in other cancer types, that could be a place you could pull from for validity evidence. If it really does need to be like tweaked and edited though, we'd recommend starting with modifying a valid measure before you start doing something that's homegrown. But potentially at this stage, that could be a time where maybe you need to pause. If there's really not any valid measures for the main things you're trying to target with your intervention, there's probably going to need to be some more preliminary work done. So doing like some pilot validation studies related to measures, or even seeing if you can collaborate with like a measurement group if that's not your forte, but work to get some measures that have been tested in your population. Yeah, so just key things to think about as you start selecting measures is try to do your best to get validated measures. Okay, and then justifying the timing of the study sessions and the assessments. So your study milestones, by milestones, I mean your sessions and assessments, they should fit with your conceptual model. So what does your model say? Like how quickly should this intervention be impacting the outcomes you're interested in? Is it something that's immediate? Is there a really delayed response to it? So it should really fit with how you're conceptualizing your intervention, but also keep in mind the population's illness trajectory, right? So if you're dealing with very sick patients or patients who may be passing away during the course of the study, you really want to make sure you're having your key milestones happening before you would anticipate a lot of them having to drop out for various reasons. And we found in our own work, it's really helpful to track how long it takes participants to complete assessments. So if you have a battery of patient-reported outcomes, if you're using a program like REDCap or other software to collect this, oftentimes those are date and time stamped. So you can see how long does it actually take people to complete the assessments. And that can be really strong to include in your preliminary studies for your next grant, is say on average, here's how long it took to complete the assessments. Because you want to make sure that you're not including needlessly burdensome measures and overly long assessments that, if there are places that you could scale down. And it's also important to think about the actual time between your milestones. So you have your study flow, right? And you have, all right, we're going to do a baseline, they're getting an intervention, and then here are follow-up timeframes. Often there's wiggle around that, right? Nobody's going to hit it at exactly the right time point. So it's really helpful to be tracking, like, how long does it actually take folks to complete your intervention? How long does it actually take them to do the follow-up assessments? And using these to inform the next steps in your study. So your study timeline really is matching up with when participants are doing the different milestones. This is particularly important when you have multiple arms. You don't want to start to get those disparate in their timing with when they're completing assessments. All right. And then moving on to testing recruitment methods. So everybody knows this who works in this space, but recruiting seriously ill patients is extremely hard, right? There are lots of difficulties with this. As you'll see in any grant application, right, you're often required to have these study timelines. Timelines are key, and that's a great place to start, but just know that you're likely going to hit some road bumps that require you to revise those timelines. One big road bump that's been talked about a lot in the palliative care literature, and we've experienced it ourselves, is gatekeeping. So gatekeeping can happen on a lot of different levels, but the key goal here, or the key point with gatekeeping, is it's when there's some party who does not want you to approach a participant about a study. So this can be family caregivers, sometimes the university ethics committees. So you can see studies getting held up in IRBs and other ethics committees because of the populations that are being studied or something about the intervention. It can also be providers if you have a recruitment method that requires you to go through a patient's provider. As you can see, a lot of gatekeeping at the provider level of providers not wanting you to talk to their patients about the study because they're afraid it may burden them. And so there are a lot of things to do to try and address this stuff up front. A key one that I think I already touched on a little bit, was this idea of not including overly burdensome like session lengths or assessments. So just thinking about as you're designing things to keep things as streamlined as possible is what are the constructs you really need to measure? Do you need a battery of 100 different items? Like what are the core things that need to be assessed? And really like how brief can you have your intervention? And just thinking about these things in the context of your patient population. And then from the provider level, there are a lot of considerations too. So if you have recruitment methods that require you to go through a patient's provider, definitely spend time to get to know those providers and to really explain your research to them and make sure that they understand the goals of it. Because often we're on the same page with the providers as we're really trying to help our patients, but making that really clear to them and explaining how it's not going to disrupt their clinic and making sure it's not, right? Like don't have recruitment processes that are going to slow down their clinics. So just keeping all of those things in mind, because the truth is that there are a lot of people who are trying to protect these patients often for good reasons, but it requires us being thoughtful about how we're engaging with caregivers, with providers. Yeah, and so just anticipating those things there, you can look them up. Lots of good articles have been published on this topic. And engage early. So as we mentioned, your study timeline, right? You may have like a 3-4 month startup period or whatever. If you're ready to get started right away. So don't delay a start date. If at all possible, get rolling as soon as you can, because other hiccups will come up. All right, and so estimating retention. So this is especially important to consider, like the percentage of participants who are completing your primary endpoint. So that's going to be whatever your primary endpoint for the next trial, for like an efficacy trial. What's the timing of that, and how many patients can you still have enrolled at that point? So that's typically how it's defined. Along with this, be carefully monitoring reasons for attrition throughout the trial. So one thing that I've started doing is, your consort study flow chart, start making that right away and fill that thing out frequently. So thinking about how many patients you've approached, how many have declined, what are their reasons for declining, why are they dropping out of the study? Collect lots of info on that if you can, to get a sense of if there are any patterns that are emerging, and try to intervene early on those things. And so there's a big literature on how to retain participants in clinical trials. And these are not just specific to palliative care, but just across the board, any type of behavioral intervention. And a general consensus from this literature is that the more strategies you try to retain participants, the better. And the types of strategies you'll see are things like flexible scheduling of assessments and study sessions, using different reminder modalities to remind participants about assessments and about intervention sessions. So we'll do things like text messages, emails, phone calls, letters. Like part of it is picking a modality that connects with the participant, right? Like if they don't like to get text messages, don't text them. But if that's something that's really helpful for them, then use those by all means. And community involvement can be super helpful to make sure that the way you're framing the study, every aspect of it really connects with your patient population. Right, and then assessing interventionist fidelity. So by fidelity, we're talking about the degree to which the protocol is implemented as intended. An interesting, inherent thing that we're assuming here is that you have a comprehensive interventionist manual. This is really a core part of doing the pilot work if you're working in a space like this, is that you have a manual that details what should happen at each session. And it's something that will be revised, right? That's part of the pilot, is figuring out what is all of this going to look like. So it's not that it's set in stone, but it is something that clearly could be reproduced, that other interventionists could try. So the manual is a core part that you'll come back to. And so as a part of the fidelity piece is you want to make sure you have really rigorous interventionist training. So we've done this in our group for a long time, where we'll have different stages of training. So the first stage is usually for the interventionist to read through the manual. So we'll have session by session, what is it there to cover? And then sometimes we have other background reading too. So it could be theoretical articles or things to just get them situated in what this intervention is doing. And then after that, we'll do role plays. So where we have a clinical coordinator, or one of us will play a patient, and we'll have the interventionist do role play sessions of each of the sessions. And then we typically will have like a checklist or competency type ratings, and make sure that the interventionist like feels comfortable to be able to deliver this before we release them into the wild. So so they go through a training so they feel like fully equipped to handle what could come up. And then, all right, so you've trained them. Now they're seeing real participants. Important piece is to regularly monitor fidelity to the protocol. And so this is a place where you could use your own homegrown type instruments to create like a checklist of what are the core key pieces to each session, and then like the degree to which the therapist was delivering those with fidelity. We often will have like a adherence, so like was the topic covered, and then like a competence too, like just a general, like was the therapist empathetic, were they warm, were they responsive to the participant. So anyway, so you go through and we usually will review a subset of these. So it's usually not feasible to review like every intervention session, but we typically will start off, we'll review like maybe the initial 3 participants, and we'll review those in depth, and then start staggering it over the time throughout the intervention. But it can provide a really useful framework for giving feedback to the interventionist. So a common thing you'll see in behavioral trials is usually adherence starts off like the fidelity starts really strong, and then can start to get a little weaker as the trial goes on. And it's called interventionist drift is one way to think about it. And it's when folks get really comfortable with the protocol, they stop referencing it as much as they may, be like, oh, I know what this session's about, and then may start to add or subtract things from the protocol. So it's really key to do this throughout the length of the trial. And then, as I was saying, like it's a tool to give constructive feedback to the interventionist about areas for improvement or the things that they're really doing an excellent job at. All right, and then acceptability of the intervention. So different ways to do this. You can take like a quantitative approach. There are validated measures of intervention satisfaction. So you can just, after they complete the intervention, there's a self-report questionnaire about how much did this meet your needs? Was this what you were expecting? Was it helpful? This is another place where it would be appropriate to do some like homegrown items of your own. If you had some really specific questions about the protocol you wanted to ask, like, was this aspect helpful? Was this aspect something that, you think would help future patients? A different approach too is you could do more of a deeper dive and do like a qualitative approach where you actually do exit interviews with participants who have gone through the trial. So these could be semi-structured, in-depth interviews where you have your interview guide and you ask specific questions about parts of the protocol and really get more of an in-depth feedback about what was helpful and areas to change. Important piece with this is to make sure the person doing the interviewer wasn't the same one who delivered the protocol. So don't have your interventionist also do the interview, because that can really bias the results, right? As it can be hard to tell the person who you've built this relationship with that there are parts you didn't really like about the intervention. So you want to try and reduce bias with that by having it somebody who hasn't interacted a lot with the participant already. Yeah, so in an ideal world, I would say do both of these, right? If you had the time and the staff, is get a quantitative measure and also get a little bit of a deeper dive. You can also do like qualitative light type work here and just have some open-ended questions on your self-report measure about like, tell me what was most helpful or what would you recommend we change? So those can be ways too, if you don't want to do like a full exit interview. All right, and then a lot of this is building towards assessing feasibility, right? So feasibility of the next trial, of a larger trial. We lean towards using a priori benchmarks. I think this is a really good way of framing things in a grant application and helping you to conceptualize like what are going to be our cutoffs for these different key indicators. So for like recruitment, retention, and acceptability. Here I've pulled a little snippet from a recent R21 I submitted to show how we put this in a names page. Like we get really specific about here are the things we're going to consider as our feasibility indicators. So you'll see we put, this many participants over this length of time. Here's our goal for attrition, session attendance, engagement, et cetera. But as I point all this out, there's a caution here too. So just like we were talking about with the effect sizes in the very beginning here of the pitfalls of small numbers, same thing applies with any of these point estimates, right? So if we were to have 26% attrition, does that mean we just stop this line of research, we say, nope, that's too much attrition. We are not moving forward with the efficacy trial. There's variability around all of these estimates. So the point is that I think it's good to have benchmarks so you can take a step back and really notice when there is something that is going wrong that needs to be addressed, but not treating these as really hard and fast rules, but saying like, this is what we achieved, this is what we were hoping to achieve, what we achieved, and here are the things we're going to do to try and correct it in the next trial. And so that's one way to frame it, is what is your degree of feasibility unless changes are made. And so I've seen others have talked about like a traffic light system. So at the end of the day, you have, your pilot's done, you have what your retention was like, how quickly you could recruit participants, all of these pieces you were looking for. And then you can think about it in terms of like a stoplight. Is like, do you have a green light? Is everything ready to go? And you could, start the next trial right away? Or is it more of like a yellow light? Is there definitely some things you need to take a step back, revamp a bit before you move to the next trial? Or is it like a hard stop, as you have seen enough and this is just not going to be feasible at all, how it's framed? I would say for the vast majority of stuff falls in like the yellow light category. The things I've seen some published examples of like a really hard stop, and would be things like just not at all able to recruit participants. Maybe if it's like a very rare disease and there are just frankly not enough participants to do a large efficacy trial. But in general, you're going to find stuff is going to fall in like the yellow light category. It's like we can move forward, but there are definitely things we identified that we need to shift for the next trial. And so that leads to, what are these barriers? What are the things that you identified? The key question here is like, what's most likely to go wrong in the next study? And this can fit in a lot of different buckets. It could be pragmatic issues. Maybe you frankly need more staff. Is it trials? Anytime you start doing a randomized trial, there's a lot involved. And so staffing can be a big deal. Is make sure you're budgeting enough to have the support you need to recruit participants, to keep them enrolled. Could be issues with the actual intervention itself. So things like maybe the number or length of sessions, those types of things need to be tweaked before you move on. If you're running into lots of recruitment issues, maybe it's something about your site. Maybe you need to consider adding additional sites at the next stage. The point with this is when these things come up is you can be explicit in your grant proposal about here's an issue we ran into and here's how we're addressing it. I think that's one of the best ways to do it, is to not try and like bury all of the issues you had, because we all know pilots are going to have issues that come up, but be explicit about it and talk about how you're going to address it. And look at things like missingness with your study measures too, is maybe there are some items that for whatever reason, participants are not responding to specific items. And so if you're having like patterns like this, is just think through, there could be things that need to be tweaked, is maybe that measure is confusing in how it's presented. I know in a few of my studies, I'll have like reverse coded items, right? So it's like all the scales moving in one direction, and then there's that one item that you have to switch the direction. And I'll frequently see missingness with those. So it's like, well, maybe there's a better measure I could be using that's not as confusing. Yeah, so just thinking about like what's likely to go wrong and what are the things that you could do to address it. And then this is a big point, is publish about your struggles. So you're not the only one who's going to run into these struggles. And I've learned so much from reading papers from other palliative care investigators who are like, here's the trial we proposed, here's all the stuff that went wrong. And you get so many ideas from that. Yeah, so I really encourage you to publish about these things and to get the word out. Do talks like this, just invite people into the hiccups you've experienced and we can all learn together. Okay, so that's a lot of me talking. I think some stuff has come through in the chat.
Yeah, great questions. Greg and I have done some answering along the way. David had a good question early. Greg put one thought in there about the sample size you presented was 10 to 75, which is a really big range.
Yeah.
And I think it's important to think about kind of why would you do that? How do you decide? Joe, any specific thoughts? Greg, other thoughts than what you typed?
Yeah, I haven't seen what Greg typed, so I could jump in, but then I'll defer to Greg. A lot of this, I think, depends on like your mechanism that you're applying to. So honestly, a lot of my sample size decisions come down to what I can feasibly do in my time frame and with my budget. and that get to answer my question. So like if these are not super applicable across the board, but in general, for like a pilot randomized trial, I'll typically want, maybe 20 per arm if it's like a 2-year award. So a lot of it is I'm thinking in like feasibly knowing the amount of staff I'm going to have and my budget and the length of the award, what can I actually do in that time with that much help? So that's one way to do it. Greg, do you have thoughts?
Hope you're muted, Greg.
Thank you. Yeah. My answer was in the same general ballpark. Is you could base the primary sample, the sample size on what you primarily want to learn. And I had given an example. If your new intervention is based on an app, maybe you can cite the literature on software usability, which might also get to 10 to 25 as just the precedent within that area. And I think I saw a comment afterwards that should you frame these as hypotheses or goals? I think I agree with that comment as well. I said, well, maybe expected outcomes, and I think just another way to say it is the thing I would most want to learn. So that's that's one approach, and of course that's always mediated through what's realistically feasible. So I think, Joe, you and I were in a similar place.
Right.
Yeah, but it's tricky, and there's you can find a lot of different guidelines. So you'll see a lot of opinions on this, but you can look up different ways to calculate sample sizes for pilots. Some of them take more of like a statistical approach, but again, with a lot of that, you run into issues of it's often going to want you to have a larger sample than is feasible for a pilot.
And I apologize, and Tammy, if you can figure out how to circulate this more generally, or maybe Naomi, I think I must have accidentally only sent my reply to the host and panelist.
No problem. I'm having trouble copy and pasting it, but we'll figure it out.
Okay.
Yeah, and
sorry about that.
That's okay. Just to kind of piggyback on that is just make sure that, from the grant writing perspective is that you're being reasonable. You can only, if you have 2 years, 10 might seem low, but if you have 2 years, 70 might seem high. So really to think about your time and money, and as well, just to justify in what you're writing is, hey, we thought about this and this is how we landed on what we decided. We had another question about gatekeeping. I put an answer in to present to the group, clinical meetings, grand rounds. Other people feel free to put in the chat, kind of strategies around how do you get past the gatekeeping. And Joe, you mentioned you've had some experiences with that. Joe or Greg, do you guys have comments on how to decrease gatekeeping?
Yeah, I can jump in first. It's a big deal, and honestly, the thing that's helped the most is at Duke they turned to an opt-out institution in 2019, I believe. So allowing certain research protocols, which is pretty broad actually, allowing you to approach patients directly, so you don't have to go through a provider. So if the recruitment method is approved, you can go straight to the patient without having to have like their oncologist introduce the study. So that's helped a ton with a lot of our gatekeeping issues. If that's not an option at your institution, though, I think, as I kind of mentioned in the slides already, is meeting with the providers who you're going through and making sure they understand like the purpose of your work and doing everything you can to not interrupt their clinic. So like I remember in grad school, we would like wait outside of patient rooms to go in and recruit and did all sorts of things that like literally me standing in the hall blocking the provider was super annoying. So just thinking through, like, is there anything I can be doing to make it like minimally burdensome on the providers? Sometimes that's also like giving them a little snippet of here's the language to introduce it. Sometimes it's not even knowing like how to introduce it to the patient and not wanting to put the thought and effort into that because you're super busy. So like writing down here are the high points and it's really a few sentences to introduce it. So I've seen that method work of here's some example language for introducing the study. Some of it, though, it gets complicated as to who you're talking about, who's doing the gatekeeping. So that's all from like if it's the provider.
Yeah, nothing to add. That was very helpful.
It's a tricky one. Thanks, Naomi. So Greg's response is now in the chat, which is helpful.
Thank you so much.
There is a good question here. Do you have advice on how to convince the reviewer funder who wants you to already have all this work done? I'm thinking about the criticism from the reviewer who wants you to look at more definitive or clinical outcomes rather than the need to focus on acceptability, fidelity, and feasibility. Great question.
Yeah.
What do you think?
Well, this is so hard. Greg will probably have better insights than I do, but it comes up a lot, right? Is then you get the reviewer back, reviewer 3, or reviewer 2 sometimes, who's like, I want this to be an efficacy trial, and that's not the stage of the research. I don't know how successful I've been because a lot of it's still under review, but I try and rebut some of that in a very respectful way, and with citing some articles that are trying to pinpoint like this is not the stage of the research yet, and that these are great points and it's what we're building towards. But yeah, I don't like trying then to retrofit my pilot to be an efficacy trial. I think that's bad on so many levels. So it's a comment that I would push back on personally, but Greg and Tammy have more experience than I do with
well,
that.
I think if you can frame a response ahead of time and don't have to push back, that's light upon light. Sometimes it's helpful in grants to discuss what were some of the challenging issues, alternatives, and why did I decide to do this. So if you make that section in a grant, that's a natural space to put things in. And one way to frame it is why didn't I do an underpowered efficacy trial? And you can cite the consort recommendations for feasibility studies that basically say don't do it. Your slide about don't look at safety, don't look at efficacy it can be backed up by those expert recommendations. So. Sometimes being able to cite those guidelines or references that are similar can help you support your case.
Mm-hmm.
Yeah, another spot to maybe put that idea is right in the specific aims page where you kind of that emphasis paragraph or what will happen paragraph at the end of, if I show this, the next trial will be an efficacy trial. So really to get your reviewers thinking right away, like, oh, this isn't an efficacy trial, but if it goes well, it will be one, to kind of ward that off early on. So we have another question of how do you...
Could I maybe add something to that, Tammy?
Yep.
I found that to be quite effective too. And if there's space, if you can describe that next trial so that the reviewers can visualize and verify that this feasibility study has literally covered all the loose ends, and to explicitly demonstrate that if they will just fund this, you're ready.
Yeah, and I'll say one thing in that same vein is I've put like brief power references for what that efficacy trial will be. Is I'll say like we're going to power to test the MCID in this efficacy trial. So I'm trying to show like I understand how to power a trial, but that's not what we're doing at this stage. Yeah, so sometimes it's helpful to be that explicit.
Well, and a beauty of mentioning the MCID like you is it like you do is it reminds the reviewer that there's a downside to estimating effect sizes from small pilot studies, as you began the presentation with.
Great. So we have a question that's really relevant to palliative care here is how do you pick feasibility cutoffs for pilots of seriously ill patient populations? So Joe, I know you have a large trial just starting. Typically I think we say around 80%, but I guess I'm wondering too, do you adjust that based on advanced stage cancer or other diseases?
Yeah, I like to think about too when is your primary endpoint is a big question. is it's like I anticipate a lot of the patients will pass away during the trial, but I do anticipate there will be enough to answer my main question at the main point, if that makes sense. So it's like you may have a 3-month follow-up and anticipate a lot of attrition by that, but your primary endpoint may be quite a bit earlier than 3 months. But as far as like setting a hard benchmark, I think there's a lot of guesswork and kind of just estimating type things. So again, like a point estimate is going to have a lot of variability around it. So typically I will pull from other larger studies in the similar area and see like how long could they retain participants. And I'll use those as my references. I'll say like in this study that had, advanced stage patients with advanced stage cancer, they had this much retention by the, 2-month follow-up, if that's the primary endpoint I'm looking at. So I'll try and find literature or even just like a longitudinal study and use that to justify like other larger trials have retained this many participants. I understand that's not always the case, as you may not be able to find studies that do that, but that's the ideal situation, is you can point to similar patient populations with a similar length of a study.
Move on to the next. Greg, anything to add to that?
No, that's
okay.
Wonderful.
Great. I think this next question, Dale, is interesting. We just had this come up as well, and I'm not actually sure how we dealt with it, but how when you're moving toward patient and community input, that sometimes that folks don't like the language around the validated questionnaires. So how do you be responsive to their input, but also keep the validated questionnaires? Be curious to hear if other people have had that happen in the chat, or Greg or Joe, if you guys have opinion on that.
That's an excellent question. I personally haven't had it come up, but it makes a lot of sense to me, as I do see the way things are framed in some of the validated measures could be off-putting or could be confusing. Yeah, then what do? Do you tweak the measure and make it a non-validated measure? I don't know. What do you guys think?
Well, I don't know, but when you don't know, the next best thing is to know who to ask. And I think the PCRC's measurement core, be the first resource that I would go to, Antonia Bennett.
Great.
Yeah, and I would think too, like degrees of modification, right? Is it's one thing if you're like tweaking one word versus like you've added lots of items, you have really switched things around. And so I think that there'd be a lot of nuance to answering that question too. And whether we're talking about like your primary endpoint or these like secondary outcomes that are not as big of a deal. Yeah, so lots of different things to consider when thinking about tweaking a validated measure.
Right. So Allie asks, can you speak more about how to incorporate the expertise of a variety of experts as you develop your intervention manual? So, there's a couple of ways I think, the very formal way you could do this within your aims, right, as focus groups or cognitive interviews. So I'm not sure if you're asking how to get that done. So, if you are, you can put it right in a pilot study, collecting qualitative work. And we do a lot of that. I'd be happy to talk more about that. There's also some resources on the PCRC website around that kind of work. The other way is just, practically how to do it is to just do those cognitive interviews in focus groups. So either with a group of patients, a group of providers. We have someone right now in our group who is asking palliative care experts as one, behavioral interventions as one, oncologist as one group. So really just like keep asking, show them pieces of the manual and kind of get that feedback. Not sure if I'm getting at your question, but I think that's kind of where you were going. Joe, Greg, other thoughts on that?
Yeah, I think that's great. To keep it really formalized, if you would like doing the qualitative interviews would be the most rigorous way, I would think. And then you can also, if that's not part of like what you proposed or what you're thinking of proposing, you can do more informal of if you just have colleagues who want to look over the materials and give you feedback.
Yeah. All right, this is a big one. for a funded feasibility pilot, when do you throw in the towel and say the proposed recruitment methods, inclusion criteria are not feasible? And how much wiggle room do you typically allow in changing things up in a funded grant?
That's a really good question.
Want me to take a try at it while you think?
Yeah, go for it, Greg.
Okay, I think if you framed your study that you have two ways to win with feasibility. You win if you demonstrate feasibility as originally written, or you win if you learn what needs to be changed to make it feasible the next time. So I think if that's the framework and things aren't working as is, so long as you figured out how to tweak it, it's probably pretty good. And the next stage the next question will be, well, what's the difference between big changes and small changes, et cetera. One of the benchmarks I use is if this is going to require an additional validation study. If you've discovered why you think the tweak is going to work, but you're not certain or you can't adequately demonstrate, that's a yellow light, and you're probably going to need an additional test before you do your definitive study. But if it's a small change and conceptually based and all of that, maybe you can just say, well, it's mostly feasible, and I learned how to tweak it. So, but I think if you reframe from must demonstrate a certain level of feasibility as is to okay as is, or learn enough to go forward, that reframing gives you a lot more flexibility.
Mm-hmm.
And I would say be gentle with your results. So I can think of two things, right? Two pilot studies right off the bat that were done during COVID that the investigators, junior people felt really frustrated about. And, my advice was, listen, you were doing this in a worldwide pandemic. Let's tell them why it didn't work and what needs to happen next. And I think if you give yourself a little bit of grace, there's things that don't work that you need to stop, but a lot of things you're learning why they don't work. And there's ways to do it better.
Yeah, learning why it doesn't work counts as a win.
Yeah.
Mm-hmm.
Yeah, and practically too, I think some of the low-hanging fruit would be inclusion-exclusion criteria is often where I would go first if I'm really having a hard time with recruitment, and it's because I've been too restrictive in who can be enrolled. Especially in palliative care trials, I see that this can be a major issue, is if you're really honed in on some very specific like symptom cutoffs and those types of things. So I think that can be a place earlier on to start to intervene if you're seeing like we are not enrolling enough patients, like seeing if you can broaden those up. And then also depends on your funding source too, and like what their guidelines are as far as what you can tweak and not tweak. And if there needs to be like a dialogue back and forth between you and the funder about things that you've changed. Yeah, because some of the like foundations I've been funded by, it's they expect this, and it's totally fine to talk to them about, hey, we're needing to revamp this because it's really not working. And they understand that's part of like the pilot process. So I would also encourage to see, depending on your funding source, what they're expecting and what is allowable for the things you could change.
Great. Yeah, we have a couple more questions in about 2 more minutes. So let's see if we can sneak some answers in. So Anne asked, if you're developing a guided web-based intervention, do you use a formal evaluation tool like the system usability scale, or more informal focus groups, investigator developed survey?
I'll take a try. Kind of as stated, there's a natural history. You would typically use the focus groups and similar more qualitative methods as you're designing your intervention. And then something like a system usability scale, something more formal and quantitative as you're formally evaluating it.
That's great. My thought was use both. So
yeah, if possible, do both.
Yeah. Great. Good. And here's the last question we'll take. How do you select who will be the palliative care team for an intervention study? literature seems to be all over the place on this issue.
As far as like who would be delivering the intervention?
I think that's probably a good way to go with it.
Okay. Yeah, I would think that there'd be a lot of different ways to go about it. And it could come from further down the road. Who do you actually want to be delivering this? Like thinking of like an implementation framework is, do you want it to be nurse delivered? Do you want it to be physician delivered or psychologist delivered? And I would start framing it around that from the beginning if possible. Of if this is your end goal is to have these types of providers deliver it, then I would start with them.
I think that's a great spot. And sometimes it's just practical. Who do you have, right? So if you don't have any of these folks at your institution or in your group, then it can be hard. But to also, I think if you can do what Joe's suggesting, it's probably your best bet. Greg, Joe, other thoughts before we let Nan jump in?
No, wonderful questions. Thank you for sending them.
Yeah, thanks everyone for asking questions and being here.
Naomi, I will go to the final slide for you.
Thank you so much. Thank you for such a rich conversation, and to everyone for joining us today. We ask that you please do complete the 1-minute evaluation coming to you by email, and we request any recommendations you have for future webinars. And do see our website and register for this summer's webinars offerings. We have next month on July 11th, Dr. Catherine Pollack presenting on how to prepare a fundable grant application. And then in August, we have Dr. Nick Dion Odom representing the PCRC's Caregiver Corps and presenting introducing factorial design within the multi-phase optimization strategy, the Project Cascade Exemplar. So we hope to see you for those. And I hope you all have a wonderful, warm summer. Thanks so much for joining, everyone. Bye.
Thanks, everybody.
Great.